Guys, we've got clinical case. We love it, right? 45-year-old man presents with a long history. Right, don't look at me, right? So 45-year-old man presents with a long history of severe recurrent peptic ulcers that have been refractory to standard triple therapy for Helicobacter pylori and high-dose proton pump inhibitors, PPIs. Okay, an upper endoscopy reveals multiple large ulcers, including some in a distal duodenum and jejunum, which is an unusual location. Jejunum, I suppose it's pronounced like that. So the patient also reports chronic large volume diarrhea and has lost 10 pounds. Which of the following laboratory findings would be most specific for confirming the diagnosis of Zollinger-Ellison Syndrome? Give me the options, please. An elevated serum amylase and lipase, positive anti-tissue transglutaminase, TTJ, antibodies, no, a markedly elevated fasting serum gastrin level, that's one, a low serum pepsinogen, I level, or 1 level. No, we have markedly elevated fasting serum gastrin level as a correct answer. So the patient's presentation is a classic textbook picture of Zollinger-Ellison Syndrome, ZES, Z-E-S, ZES, Zollinger-Ellison Syndrome, Z-E-S, no ZES, let it be ZES. The question tests the knowledge of definitive biochemical marker for the condition, for this condition. So pathophysiologist, let's understand what's going on, So why it's a markedly elevated fasting serum gastrin level is a correct option. So pathophysiology, ZES, Zollinger-Ellison, is caused by gastrin-producing neuroendocrine tumor, gastrinoma. So most commonly located in the pancreas or duodenum. The tumor autonomously secretes massive amounts of the hormone gastrin. So effects of gastrin. Gastrin's job is to stimulate the parietal cells in the stomach to produce hydrochloric acid. In Zollinger-Ellison, the unregulated massive overproduction of gastrin leads to extreme gastric acid hypersecretion. And what we've got like a clinical picture, this tidal wave of acid overwhelms the normal protective mechanisms of the upper GI tract, causing severe, multiple, and often atypically located peptic ulcers, like in jejunum. I don't know how to pronounce it correctly. The acid is so overwhelming that it's not neutralized in the small intestine, which inactivates its pancreatic enzymes, leading to malabsorption and diarrhea, and the damages the intestinal lining. Now about diagnostic test. The definitive way to diagnose this is to directly measure the source of the problem, a markedly elevated fasting serum gastrin level, typically more than 1,000 pictogram on milliliter, of course, in the setting of a low gastric pH. What about the next options, please? Give me the next options. Let's check it up. An elevated serum amylase and lipase. These are markers for pancreatitis, of course. When a gastrinoma can be located in the pancreas, it does not typically cause pancreatitis. Positive anti-tissue transglutaminase antibodies. So these are serological markers for celiac disease, which can cause diarrhea and weight loss, but not severe refractory peptic ulcers. About low serum pepsinogen level. Low pepsinogen levels are a marker for extensive atrophic gastritis, a thinned out stomach lining with low acid production. This is the physiological opposite of what is happening in Zollinger-Ellison syndrome, which is a state of extreme acid hypersecretion. So high yield takeaway from this clinical case, my beloveds: when you see a patient with peptic ulcers that are multiple, located in unusual places, distal duodenum, jejunum, and refractory to standard high-dose PPI therapy, you must suspect unusual, but it happens not very often. Zollinger-Ellison Syndrome and order. If it's you suppose that, you suspect that, an order, a fasting serum gastrin level. Get it? Stay blessed.